record this. Okay. Okay, well, let's make a start. Well, welcome, as I said, welcome everyone to paediatric teaching. Today, I mean, so usually we talk about a different disease or a different condition, but today I wanted to talk about paediatric mortality and morbidity auditing, because I think it's a very important component of quality improvement, and it's a very important aspect of registrars training, that they understand how to do proper paediatric morbidity and mortality auditing. It's really so we can learn from the events of the past, and we can improve, so we can have continuous quality improvement. That's what paediatric morbidity and mortality auditing is all about. So that's what we'll just talk about that today. It's quite a short talk, and we'll have time for questions and discussion at the end of it. I wanted to just describe how to do it and some of the principles behind good auditing. First, I wanted to just reflect on how relatively recent these concepts are. And it's true to say that before the year 2000, there was some auditing done in higher income countries, only for the previous 10 years or so, but not very much done in other less developed countries. At the start of 2000, there were a number of studies that were done that looked at auditing and the quality of care that children received in district and provincial level hospitals. And it was interesting, they all came up with very similar deficiencies or gaps in the quality of paediatric care. And there were some differences between different countries, and some differences between provincial and district, local level health facilities. But by and large, the gaps that were found were relatively similar. And these were the sort of gaps that were found in all of these studies, that most hospitals had no system of triage. And many children had, when they arrived at hospital, they had an inadequate assessment before admission to hospital. They weren't assessed for their severity of illness. They were often only given a diagnosis rather than being assessed as being mild, moderate, or severe. As I said, there was no system of triage or assessment of severity of illness. Many children received late treatment, and that was often, sometimes of course that was because they presented late, but often it was because they sat in outpatient departments or emergency departments for long periods of time, or they were admitted to wards where the doctor wasn't around, and they had delayed treatment because of that. Sometimes even up to 24 hours before seeing a doctor. So I think the delay in treatment in children requiring urgent treatment was a feature. Many hospitals had inadequate drug and oxygen supplies. This was a very particular problem, especially the supplies of oxygen, and the further down the health facilities these studies went. So down to district level, there was inadequate oxygen supplies. There was a lack of evidence-based guidelines. So we've been fortunate to have the standard treatment guidelines, but many countries didn't have those standard treatment guidelines, and they were really basing their decisions on either just what the doctors, the paediatricians thought, or what they'd been taught 10 or 15 or 20 years ago during their training, or based on protocols that had been written and didn't have a strong evidence base for them. Most of the paediatric care was focused around making a diagnosis and giving treatment, rather than monitoring and supportive care and that sort of thing. So inadequate monitoring of sick children was a particular feature. Children were admitted to wards, but they weren't being monitored on a regular basis. There was no monitoring charts, or the monitoring charts weren't acted upon when the children had serious problems with their vital signs, for example. There was a lot of dangerous intravenous fluid practices where children would receive, because of the lack of infusion pumps, children would receive large volumes of intravenous fluids, and that would cause electrolyte disturbance and edema, and contribute a lot to bad outcomes. And for many children who were admitted to hospital, they were given IV fluids and antibiotics and sometimes oxygen, but they didn't receive any nutrition. And that would go on for many days in some hospitals. There was a lot of problems with the care of very low birth weight babies in these studies, in all of these studies, and such that the outcomes for babies who are between 1,000 and 1,500 grams were very poor. Often more than half of all those babies died. And we know that, from studies that have tried to care for very low birth weight babies well, that you can have mortality rates of 25% rather than 50% or even 60%, which was what was being found in many of these studies. Another feature of these studies was that although health workers knew quite a bit about the management of pneumonia and diarrhea and malaria, they were less good at the care of the comatose patient. And children who come in either with seizures or with lethargy or in coma was actually a very common problem. We all know that it's a common presenting problem in our hospitals. But there was no good guidelines or teaching or training on the care of the comatose patient. And many, and this will be familiar to you, but many of the healthcare workers that were involved in these sorts of studies had actually had no continuing medical education or continuing professional development since graduation. And so many had been working in remote areas in many countries that without any supervision or follow-up or extra training. And finally, another common feature was that there was very poor reporting of outcomes. And so in the absence of doing auditing or reporting of data, often it was impossible to tell just what the outcomes for these hospitals were. So these were the common gaps or deficiencies in care that were found in many of these hospitals that were looked at in the first 10 years of this century. So between 2000 and 2010, there were these and many other studies that were done in low and middle income countries, and they're all finding rather similar problems. And the problems were greater the further down if they were in a tertiary hospital, the problems were a bit less, but if they were a bit further down, then the resources were less, and therefore the problems were greater. And from this these series of studies, it became clear that there are many different elements to improving quality of paediatric care. And I just want to go through this figure, because I think we learned from this that there's not just one thing you have to do to fix up paediatric care to do it better, but there's many different inputs and interventions that can be put in place depending on what the strengths and the weaknesses of your service are. And so, of course, perhaps the most important thing that was often very neglected was the human resources. And many hospitals had inadequate human resources, but there was often no program for training and accreditation. That rostering was poor, in that often out of hours, overnight and in the late afternoons, there was not an adequate number of staff being rostered on. And so therefore bad things would happen overnight, and people would wonder why, just because there's not enough staff. There was inadequate supervision, and we know that staff retention is a problem. We need to, when we appoint staff, nursing staff and medical staff, we need to have some way to maintain their working in the hospital. So to incentives for retention, and of course continuing professional development, or CME, was a very important part of improving quality of care. So that's just human resource issues. Many of these hospitals that we looked at had problems with their physical facilities, so buildings and power and water and sanitation, the essential utilities were often not there, and there was poor maintenance of facilities. There is a need, if you're going to have good quality care, to have an adequate drug supply and have appropriate systems for procurement and distribution of drugs, and the rational use and safety of drugs. So these things, medication safety is an important component of quality of care. Then we all know there's a need for some supportive technology. So to have good, adequate supplies of oxygen and safe intravenous fluids and nutrition, equipment maintenance and procurement, and now PPEs, personal protective equipment, and hand hygiene has become very important. So all of these things are essential for quality of care. We know that without clinical guidelines, then people have no guidance as to how they are going to manage patients. And so there was a need for standardized clinical guidelines like we have in the Standard Treatment Book and the WHO Hospital Care for Children book. And there's a need for training resources and a process of updating these guidelines. It's not good enough to have, we looked at some hospitals that had guidelines that were written in the 1960s and never been updated, or they'd been just added to, where someone would come along with another drug that they thought was useful in this particular condition and just add it to it, such that in some hospitals, children are on 20 or more drugs for a relatively common problem. Then the other aspect is sort of management, and often it's outside our field of influence, but clearly health services need to be financed properly. They have to be adequate to meet needs. There has to be no barrier to access. So many hospitals in these studies had fee for service, and it meant that the poorest people couldn't access the health facilities. Some countries had insurance schemes and others incentives for presenting or getting their children vaccinated. These were good things to have, and they contribute somewhat to quality of care. Then there has to be a knowledge of the health services at a community level. There has to be what we call demand for good quality health services, and that can improve quality of care if the community demands it. If they have an expectation they'll receive good quality care, and they are treated in a respectful manner, then they will come earlier. There needs to be good processes of communication and referral and transport and access to hospitals. What we're talking about today is a lot of quality improvement processes, mortality auditing, and then there needs to be, within any hospital, any paediatric ward, there needs to be quality improvement processes where we report on outcomes. We have regular morbidity and mortality meetings. We report on any adverse events that happen. We have appropriate systems for infection control and some sort of accreditation of the standards that we have. We also need emergency responses. So as well as the standard responses, we need some sort of emergency responses. So having monitoring and response charts, having a MET system. Many hospitals around the world have what's called a medical emergency team system, whereby a nurse can call a MET, a medical emergency, and the registrar or above, registrar or consultant, will come to the bedside and see the patient and assess the patient and make some changes to management. So these having appropriate systems for escalation of the deteriorating patient was seen to be very important in terms of improving quality of care. And then finally, the environment of hospitals was very important. So good quality hospitals had very good quality environments. They had child-friendly facilities and family-friendly care, respectful care for families. And they often had gardens or play areas outside where children could go, sometimes nutrition gardens or playgrounds, safe playgrounds that children could go and be in green spaces. So they were healthy environments for children. So these were, at the end of all these studies, we concluded that these were all the features that all put together meant that the child would receive good quality of paediatric care. When we look at adverse events, so we're going to turn now to morbidity and mortality auditing, then what we often need to do is really understand the case. And if a child dies, then it's important to understand the steps that were involved in leading up to the child's death. And usually it's not just one event. Usually there's a complicated series of steps that are involved. And so I've just put together a timeline of this particular child. This is a real case of a child who was 9 months old from a remote village. We can start at this number one, a 9-month-old infant in a remote village. It was referred to a district hospital with cough, and difficult breathing. This baby was unvaccinated. And this is a familiar story, I think, to many people. If you're from a remote village, the infant may be unvaccinated. They get what looks like pneumonia and they present to a district hospital. So the baby was brought by the mother to the district hospital late at night. Again, a problem if a baby presents sometimes in some hospitals at night. The baby was unable to feed and had severe chest indrawing. So we might think that this child has severe pneumonia. Now, the doctor wasn't available overnight, so was seen by nurses overnight and treated with oral amoxicillin. It's a relatively dark hospital, so it's not very possible to do a good assessment of this child, or it was in those days. The nurses had one oxygen cylinder, but that was empty, and they hadn't had a delivery of oxygen to the hospital in the last week. In the morning, because they had no oxygen, the baby was referred to the base hospital, but there was no fuel for the ambulance. So the baby was sent on a bus, a 2-hour journey from that district hospital to the referral hospital. And when the baby arrived at the base hospital at 9 a.m., the heart rate was 190. The baby was cyanosed, had a respiratory rate of 70 per minute, no pulse. There was no pulse oximeter in the CED at the time. And the baby was taken straight to the children's ward at 9:45. And then the baby arrested from hypoxia and died at 10 a.m. So you can see there's not just one step involved in the pathway to this child having a bad outcome. There's many steps involved. And if you look at it like this, that there are many different defenses that could have prevented this child from dying. So for example, if the baby had been vaccinated, it might have prevented the child from dying. Or if the mother had brought the baby during the day, it might have prevented the child from dying. It's not anyone's fault. It's just that the circumstances are that if the baby had been present during the day, then maybe the referral might have been done earlier. Thirdly, having appropriate staff on overnight, and in this circumstance, there was a good paediatric nurse on, but like it was a very dark hospital, hard to see whether the baby was cyanosed or not. Fourthly, having a better management system for oxygen so that you don't just run out of oxygen. Fifthly, having fuel for the ambulance so that instead of having to come by bus, the baby gets transported by ambulance with oxygen. Finally, having pulse oximetry in the children's emergency department would have been helpful because they would have identified the baby was hypoxic and maybe started oxygen even there. And then by the time the baby arrests in the children's ward, then it's all rather too late because all of these possible defenses have been breached. And that's what in the airline industry, air crashes are extremely rare. And that's because there's many defenses and they call them pieces of Swiss cheese. And it's only when all the holes in the Swiss cheese line up, each defense, each barrier has some holes in it. But it's only when all of these things line up that a child dies. And if any one of these circumstances had been different for this child, then it's possible that the child wouldn't have died. And so that's perhaps the theory behind what we often consider to be an analysis of the timeline or a root cause analysis. In other words, it's just telling the story as accurately as it can be told. And I think mostly when we're doing morbidity and mortality auditing, we're just trying to tell the story in a very accurate way, to try to understand the story in a way that's not blameful, but is enlightening, highlights where the gaps were. From this, the World Health Organization produced guidelines for pediatric auditing. This is how relatively recent it is that WHO and other agencies have been interested in this field. But they produced in 2019 an operational guide for auditing and review of pediatric mortality. And much of the studies that I've mentioned went into this guideline. A long time ago, Dr. Pocker will remember, but we did a similar sort of process where we started mortality auditing in Goroka. And it was we'd have a weekly or bi-weekly meeting, a meeting every week or every second week or every month, depending on how many deaths. And each death was discussed in a meeting of nurses and doctors and other health professionals. The pharmacist would sometimes come, and we would try to understand the timeline, the story, what laboratory data were available, whether there was any, whether a cause of death was known, and whether there were any potentially avoidable factors. And that's really all it is. A mortality auditing is trying to understand the story and the facts and the factors involved. And we had what was a forum for free discussion. So nurses were encouraged to provide input and give their opinions about why the child might have presented this way or why they might have died, and to give their experience as well. This is very important. And in a 2-year period, we found that half of all deaths had potentially avoidable factors. And some of those avoidable factors were not at a hospital level. Some of them were before that. Some of them were in the community or in the family, or some of them were in the primary care level. Some of them were at a district hospital level, and some of them were related to us and how we managed the patient in the hospital. And I think if we think about the timeline and all the different levels of avoidable factors, we can much better understand it. So, for example, I just give some examples of what were the potentially avoidable factors at a community level. So many children had delayed presentation of severe illness, or in many cases, some cases, sadly, there were child neglect or abandonment. And sorry, I just need to remove that. In some cases, there was a problem of primary preventative health services like vaccine preventable diseases where a child was unvaccinated, measles, particularly in that period of time. And sometimes there was a failure of disease screening programs. There were failures at a curative health services level as well. And sometimes the health facility was closed or out of stock of basic drugs, or the child was stayed in the health facility for 5 days or a week before being referred. And sometimes there was major errors in obstetric care, especially, well, obviously with neonatal deaths, or there was problems with drug prescribing. There were errors that were made in drug prescribing, or the child had been in the ward a long time and got a nosocomial infection, or sometimes we had problems with oxygen prescribing or the administration of oxygen, or we didn't give standard treatment correctly. And I think we have to be honest about our own failures, and not have to be that's the only thing that allows us to identify where the gaps are. So when we have a morbidity and mortality meeting, it's useful to review all of these types of potentially avoidable factors. A similar process has been undertaken in the Solomon Islands, and I'm pleased to say that this process has worked very well as well. And Matthew Santacabata has been involved in this, as well as Dr. Nasi and Dr. Titiulu. And the gaps that were found in their audit meetings in the Solomon Islands were a lot about communication. And I think that's something that perhaps we need to more emphasize, having good communication at handover periods, good communication between doctors and nurses, and good communication with pharmacy, and good communication with hospital managers. There was a lot of errors that occurred because of lack of good communication. All the other gaps that I mentioned before were quite common also in the Solomon Islands. And based on this, there were many changes recommended by the audit process, but they do require a process afterwards to implement change, and they require really a quality improvement team in every ward. That it doesn't have to be a big team. It can be just a small team of like the pediatrician and the head nurse, or it can be a number of other people who are interested in this. But there has to be a small team that is responsible for the enactment of recommendations, because otherwise you just have meetings and you don't enact anything. So it's important. I just wanted to go through, these are some of the principles of a proper audit, a successful audit. And some of these will be obvious to you, but I have just written them down because I think it's important that we have, when we have meetings like this, they're based on certain principles. And so firstly, you have to have regular meetings. If you don't have regular meetings, then the staff sort of think it's something that's done occasionally and they don't have to take it very seriously. So have a regular meeting, usually once every 2 weeks or certainly once a month as a minimum, but sometimes it'll be once every 2 weeks and sometimes once a week. These meetings should be confidential. They should encourage open discussion inside the meeting so that everybody has their say inside the meeting, but no discussion of specific cases outside. The only thing that's discussed outside is the recommendations and the changes that will be made, but nothing related to the case, the specific case. So health staff are not mentioned, the case itself is not mentioned, the child, the family is not mentioned by outside. So when you have robust discussion within the meeting, but then afterwards, it's very confidential. The attendance at these meetings should be voluntary, but I would strongly encourage all staff to attend. It should be a meeting where staff want to attend, and they should involve all clinical staff, nurses, doctors, registrars, residents, pharmacy, any managers sometimes if necessary. And the meeting should be non-blameful and non-threatening, and they should be very welcoming to staff. They should have a strong educational function. So instead of it just being about highlighting problems, then it has a strong teaching, take the opportunity to teach on subjects that arise during the meeting. I always find it helpful when I'm running such meetings, if I've seen a mistake or I've made a mistake, then to declare my own failings. And I think this can put junior staff at ease when they're discussing the events that happened, because if we are not honest about our own failings, about where we could have done better, then we can't expect other people to be honest about them either. I think it's really a problem-solving approach, and to solve problems like this, you need a good team. And I think you have to have a team approach to identify and solve problems. You need to get a wide spectrum of views on the cause and the prevention of adverse events or deaths and what can be done about it. And often when a child dies, then healthcare workers are quite sad. They're often quite upset that a child dies because they may have got to know the family very well, or they may have a particular liking for the child. And we need to acknowledge all health workers' efforts and try to understand how they're feeling if they've been caring for a child who has died. I think we need to move from specific cases to general issues so that we don't focus too much on the individual case, but we think about how we can improve. I always find it useful to look for common patterns of avoidable events. So instead of just reacting on a single rare event or mistake, if you see common patterns where the same mistake is being done on several occasions, then there must be a system problem, and that system problem might be fixed by teaching or education or changing some system issue or a variety of things, but you have to think about how you can fix it up. It's very important, as I mentioned before, never to single out individuals for blame, and the team leader during these meetings should emphasize how we could do better, not how you could do better, how we could do better as a team. I think it's important because, as I said, the root cause analysis shows that there are many gaps, sometimes at a community level. Then we have to think about the whole system, health system, when trying to understand avoidable factors in deaths, not just the hospital, but sometimes before that. What changes are needed in the community? And I've been to audit meetings in districts in India where they often invite the district managers into the audit meeting, or maybe even I've heard about even inviting the bus company director, the manager of the bus company, so that that transportation of people who are unwell can be improved. So sometimes also the teacher from the community. So as at a district level, sometimes these community leaders become even more important in terms of making changes that are necessary to avoid child deaths. I think that when we think about audit meetings, we shouldn't only focus on the things that went wrong, but we should focus on the things that went right, and we should compliment health workers on their successes. And usually in most of our wards, the mortality rate is about 5%. And that means that 95% who are admitted to our wards survive to discharge. That's a good thing. 95% is a success, even though 5% of children died. So it's we have to emphasize positive things as well. And when we are thinking about what recommendations to make, we should really only suggest things that are feasible and affordable, and rather than repeatedly identifying problems that can't be remedied because of external problems or financial constraints. So we all know about things we'd like to do, but what we should do what we can do, fix the things we can fix. And we should, at the end of these meetings, have clear resolutions about action items and who will do them. And then at the following meeting, we should review all the previous audit recommendations and resolutions and follow up to see if they were carried out. I always think that these meetings, you don't need to come up with lots of recommendations. If you come up with lots of them, then often they don't get done, but come up with a few that are really important and that will make a big difference, right? And it can be done, and allocate someone or the team to do them. I think, as I said at the start, I think these meetings, audit meetings, are very important, and they have a link, I think, to child rights and human rights, because we have an obligation to do justice to a life. That person lived, and we have an obligation to try to understand whether or not their life, whether we can learn something from their life and sadly from their death. This is not just a mechanical process where you have tools and forms and outcomes and frameworks. It's a very human process. And I find that, human relationships are fundamental to effectiveness. That is the relationship you have with your staff and the relationship you have with the families. And I find that audit can very much help families. I don't usually, unless parents ask, I don't usually tell them that there's going to be an audit, but often parents will ask, and I will always tell them that yes, there's going to be an audit, and we'll try to understand whether there are any gaps in your child's care, and we'll try to learn the lessons and try to improve. And I think often families really appreciate that, because they want to know that everything was done, that they want to know their child's life was valued and the death was taken seriously. And remember that in 50% of cases, there aren't any avoidable factors. And in the other 50% of cases, there are only potentially avoidable factors. It doesn't mean that just because you fix up that problem, the child wouldn't die. That's very important to understand. It's not 50% of cases are avoidable. It's just that 50% of cases probably have some avoidable factors which we can learn from and improve. On the Paediatric Society website, we've put some forms and tools for child death review meetings, and so I hope these are useful to you when you go about your meetings. But I do think it's very important that paediatric registrars understand during their training, the 5 years of their training, they should go through a process of learning about child death review meetings or mortality and morbidity meetings, and about quality improvement, and trying to, by the end of your training, you should be the ones who are running these meetings, often with the specialist pediatrician, but have a very important role in the meetings and learn how to run them properly. I won't go through the tools and everything there. I just go back to this case we mentioned at the start, where there was many holes in the Swiss cheese. And just to emphasize that, again, it's not just a matter of finding the gaps, but we have to find out what to do about it. And with this case, well, there could have been a number of things done, starting from the hospital backwards. There could have been oxygen and a pulse oximetry in the children's emergency department. There could have been a MET system. There could be monitoring charts. We could have better oxygen and staffing at the district level hospital. we could try to explore why the child was not vaccinated. And then we could have a quality improvement team that tried to enact those recommendations so that the recommendations from the morbidity and mortality meeting were put in place. So that's all I had to say today. I just wanted to go through the principles of mortality auditing, and I'm happy to answer any questions that you might have. But rather than just discuss a particular disease, I thought we'd discuss this important quality improvement process and hope that that's useful to you. Thank you.